So up next, we have a project about telemedicine cardiology from our adult side friends and neighbors. And this is fantastic work where there's been years of SURF projects working with the adult cardiology telemedicine program. Dr. Fatima Rodriguez, as well as other sponsors of this work, Neil and Vijay, who couldn't make it, but have been wonderful leaders. And this is really both valuable for the SHC cardiology telemedicine, as well as a good head start for us to learn from a program that's farther along and a little bit more mature in their cardiology telemedicine, so we can hopefully have the benefit of all of this hindsight analysis. So I'll let you all take it away.
Thank you so much. So Harry and I have been super excited to work on this project and can't wait to share the results with you. Big shout out to our project sponsors and project advisors. It has been really great working with all of them. And what we will do today, so first we will give you a quick background on the project, then we will run through some patient statistics on the patient population we have been working with or analyzed, and then eventually dive into the findings we had based on a differences analysis and a causal analysis. So as David said, this is phase 4 of a long series of telemedicine cardiology projects. So previous projects have analyzed, they have studied the telemedicine usage patterns for cardiology during the COVID-19 pandemic. And we have been looking at the outcomes of care that were related to telemedicine use in cardiology. And we really zoomed in on one outcome metric that was the number of follow-up visits for each patient over the course of 6 months. So in general, our data set ranged from January 2019 up until March 2022. So we had the pre-COVID and the during COVID period, and we focused exclusively on new patient visits and had 4 subspecialties that you can see here that we analyzed in particular. Neil, our project sponsor, has defined 8 big diagnosis groups that we have been categorizing our analysis by. Let's see, just to set the scene very quickly here, you can see how the telemedicine use changed from before COVID to during COVID for cardiology. You see this big drop around February 2020 when COVID hit the US. So in-person visits declined entirely, video visits spiked. Also reminder, this is new patient visits. And then since around April 2021, the in-person visits have stabilized around 600 to 700 visits per month, and the video visits have stabilized around 200 to 300 visits per month. So what do we see in the patient population that we analyzed? I will just highlight a few here in the interest of time. So for example, we saw that a higher proportion of female than male patients had their new patient visit in person during COVID for these 3 diagnosis groups. We also saw that the proportion of English-speaking patients was higher for telemedicine new patients during COVID compared to in-person visits before COVID, especially for chest pain and coronary artery disease patients. Interestingly, also during COVID, a larger share of telemedicine users were privately insured compared to the time before COVID for in-person visits for a broad range of diagnosis groups. We can always go back to these if you have questions later. And this is how we analyzed this. Just as an example, diagnosis group AFib. We did these tables, and interestingly, or also not surprisingly, we see that the age on average was lower for telemedicine users than for in-person patients. All right, let's dive into the differences analysis. So as mentioned, we focused on the outcome metric of the number of follow-up visits for each patient within 6 months. So what did we do? We analyzed this by provider and gave each provider a label. And this label was calculated by taking the number of follow-up visits for a patient, or the average number of follow-up visits for the patient population of a provider, minus the average number of follow-up visits for patients of this provider, like pre-COVID compared to during COVID. So the question we tried to answer with this was, for example, will providers who move to mostly telemedicine new patient visits during the pandemic change their behavior with regards to patients' follow-up visits? So will we see fewer or more follow-up visits if the provider switch to mostly telemedicine new patient visits? We actually found that the use of telemedicine and the difference in the number of follow-up visits are not significantly correlated across all diagnosis groups. This is only for the differences analysis. And even when looking at providers who used 100% telemedicine during the pandemic and no telemedicine pre-pandemic, we did not see any consistent change in behavior that was related to the number of follow-up visits. So for example, some telemedicine-only providers had on average more follow-up visits during the pandemic and others had fewer than before. You can see that here. That's across all diagnosis groups and it's really all over the place. We don't see significant correlation. And here, this is basically this delta label on the left. Yeah, no clear pattern recognizable. And here we just show you an example of how we analyze this by diagnosis group. Here again, AFib. So what do we see in this dot? This just means that, for example, during COVID, this provider A saw 100% of her new patients via telemedicine. And this provider A's patients had on average one more follow-up visit during COVID when their new patient visit was via telemedicine compared to before the pandemic, when their new patient visit was in person. So we calculated a correlation coefficient and p-value for both of these, and we see that there's really no clear relationship between the telemedicine use and a difference in the number of follow-up visits. All right, handing over to Harry.
Thanks. So yeah, as Annika just showed, we're not seeing any clear associations between the use of telemedicine and changes in the number of follow-up visits. But we wanted to run some causal modeling approaches developed and used by economists, such as those here at Stanford, to see if we can control for some patient factors and really try to estimate the causal effect of having telemedicine as your initial visit modality on the number of follow-up visits. So the first approach we used was a two-stage least squares regressions. This is a very standard econometric approach. We used provider telemedicine fraction as the instrument. This allowed us to introduce some randomness into the assignment of patients to telemedicine and in-person. And this was broken down by specialty and diagnosis group data sets. Our second approach was called instrumental causal forest. This is a newer machine learning approach. And this allows us to estimate the effect size conditional on specialty and diagnosis group. And then finally, we wanted to estimate an overall effect size of telemedicine as initial visit modality on follow-up visits, using both of these methods with all of our data combined, but controlling for specialty and diagnosis group. So before we get to our results, here are our sample sizes for our subgroups. I just highlighted heart failure and pre-op for general cardiology because they had the smallest sample sizes, but for the rest of these, we have at least 250 patients to work with, so we think that's sufficient to do our analysis. Here are the results for the two-stage least squares regression. So in this middle column, we're seeing the average change in follow-up visits estimated to be caused by having telemedicine as your initial visit modality. As we look down these subgroups, we see that some of them are estimated to increase and some are estimated to decrease the number of follow-up visits. But only 3 of these were statistically significant after we applied a Bonferroni correction for multiple hypothesis testing. So general cardiology for palpitations and interventional cardiology for coronary artery disease were estimated to cause increases in the number of follow-up visits, while electrophysiology and AFib estimated to have a decrease in follow-up visits. And then these are similar results for instrumental causal forest, except we see that only 2 of these were significant, the 2 at the bottom. The magnitudes of the effect size were smaller here, but the direction of increase, decrease was the same. Okay, and then so we tried to estimate the overall effect size of having telemedicine as your initial visit modality on follow-up visits. And what we see is the two-stage least squares model estimates a very small but statistically significant decrease in follow-up visits associated with telemedicine, while the instrumental causal forest finds no significant change. Okay, moving on to conclusions. So in most cases, using telemedicine for new patient visits appears to cause little to no change in 6-month follow-up visits. However, there appears to be an increase or a causal increase in visits for interventional cardiologists seeing patients with coronary artery disease, and there appears to be a decrease in visits for electrophysiologists seeing patients with AFib. Our next steps include conducting sensitivity analyses to test the robustness of the results with different data filters and controls. And then we want to apply our methods to other outcomes of interest, including condition-specific ancillary services and outcomes. And then soon we're hoping to submit an abstract to the American Heart Association. Thank you. Yeah, so I guess here, so this is like the two-stage least squares is suggesting that given the same patient, if you give them telemedicine as opposed to in person, their expected number of follow-up visits will be lower by 0.13, which isn't that much, but yeah.
And the covariates, like so you looked at heterogeneous effects across different diagnoses. Are there any other things that you were?
We have not looked into other heterogeneous treatment effects. No. Yeah, I think they were kind of surprised. I think they've been hearing things from various people about, oh, telemedicine causes this or telemedicine causes that. I think they're actually expecting there to be more follow-up visits associated with telemedicine just because it's a little easier to facilitate. But yeah, these results kind of suggest that it might not be as influential.
Yeah, we had a call just with Neil yesterday, and he also said it's a pretty good outcome if it actually holds true, to know that telemedicine really doesn't like decrease or have like worse outcomes. So Neil was pretty happy with what we were finding yesterday.
Mm-hmm.
Would it be possible to look at how many patients are represented? For example, I could imagine before COVID, maybe all patients on average follow up once every 6 months. During COVID, some patients follow up multiple times, something.
Mm-hmm. Yeah, we definitely could look at like the proportion of patients that do a follow-up visit.
Yeah, in terms of the follow-up visits, we also had one other outcome that we wanted to look at was, for example, how compliant patients were with their visits. So they could have scheduled a visit but not actually attended. Like, or if the threshold, for example, on telemedicine is it's easier for them to attend the follow-up visit and in person they would have rather skipped it. So that was another metric we were really interested in looking into in the future.
I'll just make one comment. As more care in both this service, but also much more broadly shifts to telemedicine, I think you two have done an incredibly valuable service for the hospital and institution, because we're going to need to understand if we're doing large swaths of previously in-person care and telemedicine, is that impacting the volumes? And certainly your analyses are also going to next look at, is that impacting outcomes like emergency hospitalizations? So the framework you've built both for this service and others is going to be really informative. And beyond that, the two complementary things you've done are really nice because, Annika, you have very interpretable results that are simple and understandable. And then here your results use all of these more sophisticated methods to make sure there's not a subtlety that's being missed or oversimplification. So it's both very valuable and very well done work.
Thank you.